Hello guys, and today we are going to discuss about the renal physiology, but this lecture is going to be more USMLE oriented, and some important points will be mentioned in this lecture regarding the renal physiology. So let's get started. This is like the basic one. Starting from the fluid compartments, as we know that our whole body is divided into water mass, okay, and the non-water mass. Water mass means that the percentage of our body that is containing water is approximately 60%, and non-water mass is 40%. We are going to just dealing with one number. And for example, if a 70 kilogram male is examined and his body content or body water containing body mass will be 42 kilogram, okay, and the non-water mass will be only 28 kilogram. So after that, regarding the total body water, from the total body water there are two compartments originating: the intracellular fluid and the extracellular fluid. The intracellular fluid has two-thirds of that body mass, okay. The two-thirds of the total body water is intracellular fluid. And regarding the kilograms, we can write the number as 28. This is 28, and the extracellular fluid is only one-third of the total body water, so it's 14. Please correct this statement that it's not 28, okay, please correct it, it's not 28. So after that, from the 14 kilogram or one-third of the extracellular fluid, 75% is interstitial fluid. It means that the water present in the interstitial tissues or interstitial compartments, and 25% is present in the plasma, okay, the plasma, the blood streams, okay, and 75% from that 14 is approximately 10.5, and 25% is 3.5 kilogram. So let's revise it. First of all, we are talking that the body content of the water is 60%, okay, and non-water mass is approximately 40%. From that 60%, we are dividing that 60% into two compartments: the extracellular and the intracellular. Extracellular fluid means that the fluid present in between the cells, in between the tissues, okay, the tissues mainly are the extracellular fluid. Intracellular means that the fluid present inside the cells or water present inside the cell. So in kilograms it's 28 kilogram, and extracellular is 14, and from that 14, 10.5 kilogram is interstitial fluid and 3.5 is in plasma. As we know that 60-40-20 rule is being applied here, because 60% is the total body water, from that 40 is intracellular and 20% is extracellular. Okay, so we are dealing with the water component. So let's talk about that. Intracellular fluid is 40%, right? And extracellular is 20%. What is the main ion present in the intracellular fluid? It's potassium. And extracellular fluid, the main ion is sodium. The mnemonic here is salty bananas, because salt is on the top of bananas. It means that salt is outside, sodium is outside, and potassium, the banana, is inside. So, and other ions like intracellularly magnesium and phosphates like ATP are present, and extracellularly chloride, bicarb, albumin proteins are present. Talking about the plasma volume, we are talking about this thing. The plasma volume is measured by the radio labeling albumin. As you know that albumin is one of the most important proteins present in our plasma, and it is synthesized by the liver. So plasma volume can be measured by the radio labeling albumin. And what about the extracellular volume? Extracellular volume is measured by the inulin and mannitol. It's not insulin, it's inulin. And inulin or mannitol are of specific characters, because these are neither secreted nor reabsorbed. They are freely filtered, so that extracellular volume can be measured by the inulin concentration, okay. And another term is known as the serum osmolality. What is serum osmolality? Serum osmolality is defined as the amount of solutes present in per kilogram of water, the milliosmol of solutes present in kilogram of the water. So our plasma osmolarity is approximately 290, we can say 275 to 295 milliosmol per kilogram of water. And what about the plasma volume? We were measuring plasma volume by labeling albumin, right? So what's the formula for that? It's the total body volume multiplied by the 1 minus hematocrit. Okay, it's the formula for the uh, plasma volume, and it's very important because the what is hematocrit? Hematocrit is nothing but the fraction of the blood that is accompanied or occupied by the RBCs. And what is the condition that we call that when there are large amount of RBCs? We call it polycythemia, and one of the most specific term for that is polycythemia vera. So let's talk about glomerular filtration barrier. As we are discussing the renal physiology, this is the basics for the renal physiology. What is the filtration barrier? We have to know that filtration barrier consists of three parts or three like layers. First is the glomerular capillary endothelial fenestrated layer. This is, as you can see, this layer is fenestrated, right? So this is the glomerular capillary layer, and these capillaries are fenestrated. The size for that fenestration is approximately 70 to 100 nanometers. Okay, and after that, the second layer for the glomerular filtration barrier is the glomerular basement membrane, and it's of very important. This one is the glomerular basement membrane because the glomerular basement membrane plays a critical role in filtration. It is negatively charged, but why? Because glomerular basement membrane is composed of heparin sulfate and laminins, fibronectin, glycosaminoglycans, these all impart negative charge to the glomerular basement membrane. And what exactly the collagen that is present in GBM? It's collagen type 4, and you need to remember that all of the glomerular basement membrane in our body, like alveolar basement membrane, they also contain collagen type 4. Okay, and there are a lot of collagens, right? Type 1 is present in bones, type 2 is present in cartilage, type 3 in the many places on our body like tissues, etc., and type 4 is basically the component for the basement membranes. And the third layer for the filtration barrier is the visceral epithelial layer consisting of the podocyte food process. So what does it mean? As you can see that these cells contain food processes, and these food processes are of great importance when it comes to the filtration. And these are nothing but the visceral epithelial layer of the glomerular or the Bowman's capsule, because the Bowman's capsule consists of two layers. Let's see in this diagram. First of all, the Bowman's capsule contains two layers. This one is the parietal layer, and this is the visceral layer. The visceral layer of the Bowman's capsule is known as the podocyte. So in this diagram, we can appreciate the three layers for the filtration system. First is the endothelial cells, fenestrated endothelial cells to be more specific. Then comes the basement membrane, and then are the podocyte layers, which are known as the visceral epithelial layer of the Bowman's capsule. And as I have told you that the filtration barrier contains negative charge, and why is that so? Because albumin is a protein that is very essential to our plasma, and it's of very small size. It means that albumin can easily pass through this filtration barrier. So the person will suffer from albuminuria. But does it happen normally? No, it does not happen, because albumin is a protein and it contains negative charge, and the basement membrane also contain negative charge. So negative will repel each other, so we will not see albumin in the urine. And what about the podocyte food processes size? The size between the podocyte food processes, this is known as the filtration slit or slit diaphragm, and its size is approximately 40 to 50 nanometers. What was the size for the fenestration endothelium? It was 70 to 100. In other books, they are written 60 to 100. We will We will focus on 70 to 100, and about the slit diaphragm it's 40 to 50 nanometers, and they prevent the entry of molecules that are greater than 40 to 50 nanometers. Let's talk about the renal clearance, and renal clearance is of very importance because these are some terminologies, some of the formulas that we need to know as far as the renal physiology is concerned. First of all, what is the definition for the renal clearance? It's the volume of plasma from which the substance X, we can say that substance X is completely cleared in urine per unit time. It means that from the plasma, a substance X is being cleared into the urine in a unit time. It means that the clearance of substance X. What is the clearance of substance X? We can write that clearance of substance X is equal to the urine concentration of that substance multiplied by the urine flow rate divided by the plasma concentration of that particular X substance. This is simply the renal clearance, nothing too fancy, nothing too difficult. This is the renal clearance, that a substance X is completely cleared into the urine from the plasma in a particular time. So regarding the clearance, if a clearance of particular substance X is greater than GFR, what does it mean? If clearance is greater than GFR, it means that something is secreted into that luminal fluid, because the in for example, if a substance is neither secreted nor reabsorbed, so clearance of the substance must be equal to GFR. But if clearance is greater than GFR, it means that there is active secretion, that tubular secretion is being involved of that substance. If clearance of the substance is less than GFR, it means that particular substance is being reabsorbed. There is tubular reabsorption occurring. And what if the clearance is equal to GFR? It means that there is no tubular modification, there is no net secretion or tubular reabsorption. That's exactly what we need to know about the renal clearance. Let's talk about the GFR. What is the definition for glomerular filtration rate? It is nothing but the amount of plasma that is filtered into the glomeruli in 1 minute. And 1 minute is of great importance because units for GFR is ml per minute. Okay, and what is the normal value for GFR? It's approximately 120 ml per minute. And to be more specific and to tell you something even more like relevant, is that the a substance inulin. What was inulin used for? It is used to measure the extracellular volume, right? Inulin or mannitol, we have discussed that. Inulin clearance can be used to calculate the GFR. What does it mean? For example, clearance of inulin is equal to GFR. That's what this line tells us. The clearance of inulin is equal to GFR because inulin is neither reabsorbed nor it's secreted, it is freely filtered. So we can write that inulin clearance is equal to GFR because it's neither secreted nor reabsorbed. So in place of inulin clearance, we can write that urine concentration of inulin multiplied by the urine flow rate divided by the plasma concentration of inulin, and this is equal to GFR. So in clinical practices, we use inulin to measure the GFR of that particular patient, and it's of very importance, right? And another substance is also used to calculate the GFR. It's known as the creatinine. But creatinine, there's something issue with the creatinine, is that the creatinine is slightly more secreted. So it's freely filtered, we have understood that, and it's neither reabsorbed, but it's slightly bit amount of secreted. It means that the GFR would be overestimated. For example, if a patient GFR measured with inulin is 125, so when measured with creatinine, it becomes 128 because the creatinine is like the overestimation of GFR. Okay, so creatinine is also used in clinical practices, but not more than inulin because inulin is like the exact estimation of the GFR. And talking about the pressures, these pressures are very important as far as filtration is concerned. So first of all, for example, this is the I am drawing the afferent arteriole, this is efferent arteriole, and this is the Bowman's capsule. Okay, so first of all, we have to discuss that what are the favoring pressures that favor the filtration, and what are the pressures that opposes the filtration. First of all is the capillary hydrostatic pressure. It's capillary hydrostatic pressure. It is like the favoring force for filtration because it pushes all of the content from the capillary into the Bowman space, so it's good for us. Next pressure is the capillary oncotic pressure. Capillary oncotic pressure is the pressure that is due to the plasma proteins like albumin, globulin, fibrinogen. They exert a pulling force. They do not allow filtration. So this is the opposing force for the filtration. And what about the Bowman space? Is there no forces present in the Bowman space? No, there are. There are the Bowman's hydrostatic pressure. Bowman's hydrostatic pressure, it is like exerting the outward force, because in case of capillary, the capillary hydrostatic pressure was also exerting a outward force. So Bowman's hydrostatic pressure is the opposing force. And what about the Bowman's oncotic pressure? Bowman's oncotic pressure pulls the water or fluid inward. But in like practical purposes, the Bowman's oncotic pressure is zero because there are no proteins physically or present in the Bowman space. So capillary hydrostatic pressure has a value of 50. Okay. Bowman space hydrostatic pressure has a value of 10. Capillary oncotic pressure is a value of 30, and the Bowman's oncotic pressure is equal to 0. So favoring forces was 50 plus 0, and we have to minus it from 30 plus 10. So what is the net filtration pressure? It becomes 10. Okay, so 50 minus 40 is 10. So under all physiological circumstances, the net filtration pressure or net filtration force is favoring the filtration unless or until there is a greater amount of opposing forces and less amount of favorable forces. So that's about like glomerular filtration rate. So let's talk about the renal blood flow autoregulation. What is autoregulation? In case of hypertension or hypotension, the blood flow towards the kidney increases or decreases respectively, but it alters the GFR accordingly. If there is high blood pressure, there would be high GFR, and if there is low blood pressure, there would be low GFR. But kidney have autoregulatory mechanisms that prevent that to happen. First of all, myogenic mechanism, and second is the tubulo-glomerular mechanism. For example, if there is hypertension, okay, if there is hypertension, there is increased arterial pressure, so large amount of blood is flowing towards the afferent arteriole. But do we need to afford that? No, kidneys have mechanisms, right? So it activates the vascular smooth muscles, and they cause the vasoconstriction of afferent arteriole. Because this is afferent arteriole, the systemic blood pressure is high, so large amount of blood is flowing towards the glomeruli. Due to the activation of vascular smooth muscle, there will be constriction of the afferent arteriole, and less amount of blood will be flowed despite the hypertension, and it causes the low renal blood flow. So it's good for us. So it will lead to low GFR because originally GFR was high. According to the tubulo-glomerular feedback, there are special type of cells present at the junction of the distal tubule and the ascending limb of loop of Henle. These are known as the macula densa. And macula densa are nothing but the chemical receptors. These are like chemoreceptors. What did they sense? They sense the amount of sodium chloride reaching there. For example, consider the GFR is very high. GFR is very high. So in the proximal convoluted tubule, most of the reabsorption occur, right? But due to the tubular fluid flow is very fast because GFR is very high. Do the proximal convoluted cells have the time to capture the sodium chloride? No, they will not have the time to capture the sodium chloride. So eventually large amount of sodium and chloride will be reaching the distal part of the nephron, that is nothing but the macula densa, and macula densa cells recognizes this high concentration of sodium chloride as a trigger, right? So they will cause the paracrine driven vasoconstriction. They will also cause the vasoconstriction of afferent arteriole. In turn, it will cause the low renal blood flow, and that's exactly what we need. In case of hypertension, there was a large amount of blood flowing towards the kidney, and now we have vasoconstricted the afferent arteriole, so there will be low renal blood flow and so low GFR. That's exactly what we need, and that is the autoregulatory mechanisms. Let's talk about the effective renal plasma flow. What is effective renal plasma flow? Renal plasma flow. It's the volume of the plasma that is effectively filtered by the kidneys in unit time. And more specifically, what substance clearance is used to measure the effective renal plasma flow? It's para-aminohippuric acid. Para-aminohippuric acid clearance, it means that the clearance clearance of para-aminohippuric acid is used to estimate the effective renal plasma flow. And what clearance substance is used to measure the GFR? It was inulin clearance, right? It was inulin clearance, but para-aminohippuric acid clearance is used to estimate the effective renal plasma flow. So what we can write here, the formula is being repeated. Urine concentration of para-aminohippuric acid multiplied by the urine flow rate divided by the plasma concentration of para-aminohippuric acid, and that's it. Talking about the cardiac output, about what percentage of the cardiac output is renal blood flow? Renal blood flow, for example, cardiac output is 5 liters in 1 minute, right? So the renal blood flow will be 20% of that 5 liter, it's 1 liter in 1 minute. So 20 to 25% of the cardiac output is renal blood flow. And what is the formula for the renal blood flow? It is renal plasma flow divided by 1 minus hematocrit. And these are some formulas that are used in the like foundations for the renal physiology, but these are worth mentioning. So renal plasma flow by 1 minus hematocrit. And what is hematocrit? Hematocrit is nothing but the fraction of the blood that is occupied by the RBCs, because the para-aminohippuric acid, talking again about the para-aminohippuric acid, this is a substance that is 20% filtered. It is 20% filtered. So where the 80% rest goes, it is 80% actively secreted. It means that 100% of the para-aminohippuric acid is being excreted. There is para-aminohippuric acid entering the renal artery. It is 100% excreted. So do we find para-aminohippuric acid in the renal vein? No, we do not find the para-aminohippuric acid in the renal vein because it's already being excreted 100%. So that's why we use para-aminohippuric acid clearance to measure the effective renal plasma flow. Talking about the filtration, and to be more specific, it's filtration fraction, right? It's filtration fraction. What is filtration fraction? It's the fraction of the plasma that is filtered into the glomerula in unit time. For example, 120 ml per minute, it's the normal value for GFR. Okay, it's like the GFR. And the amount of the plasma is 600, because I taught you that 1 liter is coming towards the kidney and 1 liter is 1000 ml. We can write 600 is plasma and 400 are the white blood cells, red blood cells and platelets. From this 600, 20% is filtered. and 20% of that 600 is 120 ml. So 120 is the filtration fraction, the amount of the plasma or the fraction of the plasma that is filtered. The formula for the filtration fraction is the GFR by the renal plasma flow. GFR is 120 and renal plasma flow is 600, so it became 0.2. So we can write 20%. 20% is the filtration fraction physiologically. So it's 20%. We have discussed that GFR can be estimated using the creatinine clearance or inulin clearance, right? So talking about in this diagram, we can appreciate that this is afferent arteriole, this is efferent arteriole, okay, this is efferent arteriole. What is the major dilator for the afferent arteriole? It's prostaglandins, PGE2, mainly PGE2, prostaglandin E2 is the preferentially dilate the afferent arteriole. It means that prostaglandin are the main dilators for the afferent arteriole. Consider the word afferent, right? And what about the efferent arteriole? The major constrictor for the efferent arteriole are the angiotensin 2. Angiotensin 2 is produced from angiotensin 1, right? It means that the afferent arteriole are dilated by the action of prostaglandins and efferent arteriole constricted by the action of angiotensin 2. So if they're activator, they must be inhibitors, right? So they are non-steroidal anti-inflammatory drugs that inhibit the production of prostaglandins. But how? Because prostaglandins are produced from arachidonic acid metabolites by the action of cyclooxygenase enzyme, COX-1 mainly, and prostaglandin E2. Okay, prostaglandin E2 or prostaglandin series is produced from arachidonic acid by the action of COX-1 cyclooxygenase enzymes. These non-steroidal anti-inflammatory drugs, they block the action of COX. It means that prostaglandins are not synthesized, so they are inhibitors for the prostaglandin. And what about the angiotensin 2? Angiotensin 2 is produced from angiotensin 1 is converted to angiotensin 2, right? By the action of which enzyme? The enzyme that is present on the vascular endothelial cells in the pulmonary circulation, it's ACE, angiotensin converting enzyme, and this enzyme is inhibited by the angiotensin converting enzyme inhibitors, okay, like captopril. These are inhibitors for the ACE, and when ACE inhibitors are working, so angiotensin 2 will not be produced and they will not constrict the efferent arteriole. Okay, that was about the filtration. Let's move. So changes in the glomerular dynamics. First of all, we will discuss that GFR, the renal plasma flow, and the filtration fraction. We know that filtration fraction formula is GFR by the renal plasma flow. Talking about some dynamics. So, what if there is afferent arterial constriction? As I've told you that if the afferent arterioles, right? If the afferent arterioles are constricted, it means that the renal plasma flow is decreased, less amount of plasma is coming towards the afferent arteriole, right? And the GFR would be decreased automatically. So what about the filtration fraction? It will decrease also? No, because the both components, the numerator as well as the denominators are decreasing, so there will be no change in the filtration fraction. It's important. For example, if there is efferent arterial constriction, it's efferent arterial constriction. If we constrict the efferent arteriole, the renal plasma flow will decrease. It's like logical. Renal plasma flow will decrease, but GFR will increase. But how? Because when we constrict the efferent arteriole, there is backup pressure towards the afferent arteriole, and this pressure creates the hydrostatic pressure, and capillary hydrostatic pressure is a favoring pressure, right? So it will increase the GFR. And what about the filtration fraction? GFR is increased and the renal plasma flow will decrease, so filtration fraction will increase. Plasma protein concentration is being increased, it will have no effect on renal plasma flow because protein concentration cannot affect that. But can they affect the GFR? Yes, they can, because protein concentration develop the oncotic pressure. And when there is high oncotic pressure, there will be less GFR because oncotic pressure is a opposing pressure towards filtration. So filtration fraction would be decreased because GFR is decreased. When the plasma protein concentration is decreased, it means that oncotic pressure is also decreased. So renal plasma flow will not change, but GFR will increase and filtration fraction will increase. What about the constriction of ureters? If ureter are being constricted due to any reason, due to urolithiasis or nephrolithiasis, the backup pressure will develop, and this backup pressure will create Bowman's hydrostatic pressure, and Bowman's hydrostatic pressure is opposing pressure towards the filtration, so it will decrease the GFR, it will not change the renal plasma flow, and it will decrease the filtration fraction. One very important point regarding the dehydration, and I have mentioned it in the here as well as I've mentioned here. Does dehydration increases the filtration fraction or it decreases the filtration fraction? It will increase the filtration fraction, but it's very strange because dehydration will decrease the GFR. It will also decrease the renal plasma flow, but how it's going to increase the filtration fraction? The formula for the filtration fraction is GFR by renal plasma flow, right? So it means that GFR is being decreased due to dehydration, due to hypovolemia, due to hypotension. Renal plasma flow will decrease more. Okay, it will decrease more as compared to GFR. So filtration fraction will increase. You know that when the denominator will decrease more, the uh, consonant present on the opposite side of equation will increase. It's like the mathematical rule, right? So it's like that dehydration will increase the filtration fraction. One other question for you is that will the filtration fraction of a patient in the early stages of shock be higher or lower? Because in case of shock there will be hemorrhage, right? There will be hypovolemia, there will be like dehydration crisis. So will the filtration fraction increase or decrease? So let's talk about it. Renal plasma flow will decrease. Renal plasma flow will decrease automatically. So renal autoregulatory mechanism will compensate and they will dilate the afferent arteriole. They dilate the afferent arteriole. And in the early stages of shock due to autoregulatory mechanisms of the kidney, afferent arterioles are dilated and they will increase the GFR and they will increase the filtration fraction. So that's all about the early stages of shock. What is the calculation for reabsorption and secretion rate? It's very simple. First of all, what is filtered load? Filtered load is GFR. Let's write here. Filtered load is equal to GFR multiplied by the plasma concentration of that substance. Filtration load of the substance X is equal to GFR multiplied by plasma concentration of that substance, and excretory load of the substance X is equal to urine flow rate multiplied by the urine concentration of that substance X. Okay, so what does it mean? For example, if the filtered load is greater than the excretory load, what does it mean? If filtered load is greater than the excretory load, it means that reabsorption has occurred, right? Because excretion is not equal to filtration. Filtration is more and excretion is less. So something in between has minused. So reabsorption has occurred. What if the filtration load is less than excretory load? It means that something is added into the filtrate, something is added into the luminal fluid. So secretion. And if the filtered load is equal to the excretory load, it means that no tubular modification has occurred. There is neither secretion nor reabsorption. And what is the substance that is neither secreted nor reabsorbed? It's inulin. And what inulin was used for? It was used to calculate the GFR, inulin clearance mainly. Last but not the least is the glucose clearance. What we know, what we can discuss about glucose clearance is that first of all, Important is the normal plasma glucose is approximately 60 to 120 milligram per Dalton, but in normal ranges we can write it as 125. Okay, 125. In the proximal convoluted tubule, there are specialized sodium glucose co-transporters. Listen very carefully because it's like a concept regarding this graph. Sodium glucose transporters, they transport 100% of the glucose. For example, if 100% is filtered, 100% will be captured by the PCT cells. In adults, the plasma level of glucose when it becomes 200, because normally it was 125 or 120. When it reaches 200 milligram per Dalton, it means that there is high level of glucose present in the blood. So kidney starts to release the glucose into the urine. Glucosuria begins. And this is known as the threshold. Its threshold at rate of 375 milligram per Dalton. Okay, it means that at 200 milligram per Dalton, see in this graph, at 200 milligram per Dalton, the threshold start. Renal threshold means that some amount of excretion of the glucose begin, right? But at 375 milligram per Dalton, there will be extreme excretion. First of all, let's talk about this graph. Here is the glucose concentration and there are the glucose transporters. So when the glucose is filtered, all of it is reabsorbed. All of it is reabsorbed 100%. But when it reaches the 200 milligram per Dalton, some of the transporters, which are sodium glucose transporters, become saturated. But some, not all. They become saturated and reabsorption decreases and excretion starts. But it's like a splay. Splay is not instant or not very drastic. It's like a fold, like a curve in the graph. It's a splay. It's like gradual splay, you can say. Reabsorption slightly decreased and excretion begins to happen, right? And at the level of 375 milligram per Dalton, I have told you that some of the transporters were saturated at this point, but at 375 all of the transporters, which are sodium glucose co-transporters, are fully saturated, and then reabsorption stops because these transporters have reached their T max. They have reached their Tmax, transport maximum. So they will not reabsorb any more glucose, so excretion will become parallel towards the filtration. All amount of filtered glucose after the transporters have been saturated will be completely excreted. There will be no net reabsorption of the glucose after 375. Okay, it means that transport maximum reaches at 375, but renal threshold reaches at 200. It means that the renal threshold reaches before than the transport maximum, and this was the point that I needed you to know. And this phenomena for the splay is due to the heterogeneity of the nephrons. Some nephrons have transporters that are not saturated yet, but some nephrons transporters are saturated early, some saturate late. So there is heterogeneity in the nephron transporters. That's why there is curve, there is titration curve, there is like a splay phenomena going on here. So but this is due to the 375 like thing. Okay, but in pregnancy, when all of the substances filtration will increase, all of the substance filtration will increase and glucose filtration will also increase. In case of pregnancy, although it's physiological, but pregnant women can have glucosuria at normal glucose levels, like not at 200, but the borderline between 200 and the normal glucose. So this starts to glucose urate. Okay, it means that due to increase in filtration of other substances as well, glucosuria can happen early in pregnant women. Okay, And glucosuria is important clinically due to diabetes mellitus. This last concept is very important. One is the pregnancy, right? In pregnancy conditions, the glucosuria can begin at normal plasma glucose level as well. But in case of, we have discussed the sodium glucose co-transporters 2, SGLT2. These are the transporters that were transporting glucose, right? That were reabsorbing glucose. They are inhibitors to these transporters known as flozin drugs. And these flozin drugs, when they block the SGLT2, can these transporters take the glucose? No, they cannot, and it will lead to glucosuria even at low concentration than 200 milligram per Dalton. Although the body or the serum glucose have not reached 200 milligram per Dalton, but the patients using flozin drugs, they will block the transporters. They cannot take up the glucose, so glucose will be automatically excreted. First in the pregnancy conditions, and second is the flozin drugs. So that was for today, and I hope you understand the basics regarding the renal physiology. It's like USMLE oriented, and I will see